Good morning to everybody. My name is Vasilis Venizelos. I'm the president of the Hellenic Society of Breast Surgeons, and I would like to welcome you on board the fifth webinar of our society. The program is very interesting. All the speakers are very well-known speakers and very expert in field of the breast cancer. And I would like to congratulate Dr. Anastasakou and Dr. Kondoulis for their effort to make a very interesting program. I don't want to spend your time, and I would like to pass the microphone to Dr. Anastasakou to start this webinar. Thank you very much again.
Thank you very much, Dr. Venizelos. Dear colleagues, it is really a great privilege, an honor, a pleasure to welcome you on board of the fifth webinar of the Hellenic Society of Breast Surgeons. I would particularly like to thank the renowned international faculty for joining us in this webinar about innovations. Innovations are very important. Our practice of today is the innovations of yesterday. So thank you very much. And I would like to give the microphone to Dr. Kondoulis.
Hi, everyone. On behalf of the Hellenic Society of Breast Surgeons, Michalis Kondos and I, we're going to moderate the first panel with the title, Wire-Free, Radiation-Free Surgical Planning and Guidance, Which Device to Choose. We're happy to host a very interesting panel of experienced surgeons talking about these new techniques. We're happy also to have two panelists, a panelist that will join us at the end of each talk. It's Dr. Yazan Massanat and Professor Gianluca Franceschini. Yazan is a consultant oncoplastic breast surgeon at the Aberdeen Royal Infirmary and a senior lecturer at the University of Aberdeen. And most probably everybody knows him as a founder of the iBreast book. Gianluca Franceschini is a professor of surgery at the Catholic University of Rome and head of oncoplastic breast surgery at the University Breast Unit in Rome. Now let's start with the first speaker. First speaker is Professor Mokbel. He will tell us about Savi-Scout guided localizations. He's a chief breast surgeon at the London Breast Institute of the Princess Grace Hospital and professor of breast cancer surgery at Brunel University. He's an expert on this subject. He lectures internationally on Savi-Scout. His presentation is pre-recorded, so first we will watch the video presentation, and after that Professor Mokbel will be with us to answer any questions that we may have. So if we're ready, let's start with the video.
Good evening, everyone, and it gives me a great pleasure to present our experience with the use of Savi-Scout for localizing non-palpable breast lesions at the London Breast Institute. By the way of introduction, I would like to highlight that we previously evaluated the use of Maxeed and Localizer prior to evaluating the Savi-Scout, which is our current preferred method of localization. The limitations of wire-guided breast surgery are well documented, ranging from inflexible scheduling to protrusion of the wire that can be troublesome for the patient in terms of discomfort and anxiety, and the possibility of wire dislodgement or transection. In addition, it is very difficult to plan accurate incision with wire-guided localization since the surgeon doesn't know precisely where the tip of the wire lies. The additional limitations are related to issues Related to the wire itself, it is difficult sometimes to insert in very dense breast tissue. The choice of dissection route also difficult to predict accurately, in addition to the risk of needle stick injury due to the sharp end of the wire, to which the surgeon is blind in terms of application. This is just an example of a standard method of localization. Many patients, in fact, in my practice, feel very anxious in the clinic as soon as we used to mention the word wire, telling them that we need to insert a wire to localize this cancer. That immediately triggers anxiety for them because of the nature of the instrument used. The alternatives to wires have started emerging since the beginning of the millennium. The first wire-free alternative was the radioactive seed localization approach. This has addressed many of the limitations of wires and has proved to be non-inferior in terms of localization, and in fact was found to be more cost-effective. However, this also has limitations because radiation is involved in this method. The radioactive seed needs to be inserted within 5 days of surgery, which limits the flexibility in scheduling introduced by the technology. Furthermore, the fact that it is radioactive, it requires a special license and extensive regulation requirements and documentations. And this has formed a barrier towards its wide adoption. These limitations of radioactive seeds have stimulated research into new methods which are radiation-free, but at the same time wire-free. These are now well recognized, including the SavvyScout, made by Merit Medical, and this utilizes infrared light and radar. MagSeed, which utilizes ferromagnetic seed and a Santimag system to activate it and detect it. Thirdly, the localizer, which utilizes a radio frequency tag that can be detected by an external probe, and this is made by Hologic. These are the main three radiation-free, wire-free technologies for breast localization, and we have evaluated all of them at our center. This is really the system. You can see the console with the probe attached to it on the left side. Here you can see the reflector, which is 12 by 2 millimeters in terms of dimensions, quite small. This is a specimen radiograph showing the excision. These technologies address, as we said, the limitations of the wire, and the advantages include that the system avoids dislodgement and migration. In fact, the migration of SavvyScout is extremely low. It decouples surgery from radiology in terms of scheduling, which is a very important benefit for the patient and the healthcare providers. We nowadays tend to deploy the SavvyScout reflector at the time of biopsy. It improves our surgical access planning with the potential improvement in the aesthetic outcome as we plan our scars in a very good position to access the tumor. There is real-time navigation with the digital display of distance in millimeters from the surface of the probe to the target. Furthermore, it facilitates targeted axillary dissection. So the system of SavvyScout utilizes a deployment needle that is 16 gauge. This is a quite friendly needle to use by the radiologist compared with, for example, 12 gauge needle of Localizer. Another distinct advantage of SavvyScout over other radiation-free technologies is that it produces minimal MRI artifacts. The artifacts that we have observed in our studies never exceeded 5 millimeters, whereas these artifacts and the MRI voice signals generated by Localizer is approximately 2.5 centimeters, and by the Maxi approximately 4 centimeters. Because of that advantage, it allows us to deploy the reflector at the time of biopsy, and it is licensed for long-term placement in human tissue. The detection range of the SavvyScout is up to 6 centimeters with accurate signal detection and definition. Furthermore, the SavvyScout is very easily visible on ultrasonography compared with the Localizer, the tag, and with the Maxi. Sometimes we have to look for the marker with ultrasound scan, and we find it extremely easy to detect. Finally, the design of the SavvyScout reflector makes it resistant to migration. I think that's related to the relatively narrow width of the reflector, 2 millimeters, but also the presence of antennae at each end, which act like an anchoring part of the reflector into human tissue, and therefore migration extremely rare with the use of SavvyScout compared with other markers. Our experience initial experience, in fact, consisted of 72 localizations. So 72 reflectors were deployed in 67 patients. 57 of these patients had therapeutic excision of malignancy, which is either screen detected or became an impalpable or non-palpable after neoadjuvant systemic therapy. 10 patients had diagnostic excision of lesions which are usually indeterminate, B3 or benign on core biopsy. Out of the 72 localizations, 67 were deployed under ultrasound guidance and 5 were deployed stereotactically. The mean interval between deployment and surgery was almost 19 days, and that really confirms the flexible scheduling associated with this technology. This is the form that we utilize to collect data. This form was filled in the clinic, in the radiology suite by our radiologist first, and then transferred electronically to the patient records and subsequently completed in the operating room, and thereafter in the outpatient when the pathology is reported and the patient is reviewed. So what did we find? First of all, the deployment was relatively fast. The median, in fact, duration of deployment by the radiologist was 5 minutes. This compares with 11 minutes for wire-guided localization. So this is really important advantage. We are already seeing improvement in time efficiency in the radiology suite. How accurate our deployment? The distance from deployment to the target lesion was only 1.1 millimeter on average. That is pretty close. We had 6 patients, in fact, who had MRI after SavvyScout deployment. And when we looked at these artifacts, they were all less than 5 millimeters. Overall, the rate of successful localization was 99% and retrieval was 100%. The median operating time was 28 minutes. That is essentially from incision to closure. Did we notice any migration? Not at all. the migration incidence was 0. And we define that as movement of the marker by more than 5 millimeters from the initial deployment position in the control film. Although all the reflectors were retrieved and all target lesions were removed, we had one case of signal failure in the operating room. And we attributed that to the use of, if you like, our old-fashioned light system, which has been now changed in the operating room. And that particular reflector was deployed very superficially in a patient with very thin skin. And we think that the old-fashioned light system deactivate the infrared marker in that particular patient. However, we were able to retrieve the marker and excise the lesion accurately. Now, if we look at the pathology of the tumors that we removed, the size ranged from 0 to 67 millimeters. 0 reflects that some of the patients achieved pathological complete response after neoadjuvant systemic therapy. The median specimen weight was less than 20 grams, 19.6 grams, and that's really important. So we're removing very much limited amount of breast tissue to achieve a very high incidence of clear surgical margins. Only 7% of patients had positive radial surgical margins that required re-excision. 7% compares with national figures in the UK of 17%, and compares very favorably with other studies using wire-free guided technology. In fact, the 4 cases who had positive margins, 3 of them required mastectomy because the disease was very extensive, and 3 of them had no disease in the re-excision specimen, and only 1 patient had residual disease. When we looked at the imaging before and the pathology size after, the preoperative imaging underestimated the size of the tumor by more than 100%. So it was nothing really to do with the use of this particular technology. It was mainly related to the nature of the tumor, mainly in lobular cancers, where the radiologist thought that the tumor was only 1 centimeter and turned out to be, in one case, 67 millimeters. However, this is still a very low incidence of free operation of 7%. When we looked at the feedback from patients, surgeons, and radiologists, the mean satisfaction rate by patient was 9.7. This is on a linear analog scale from 0 to 10. Radiologists were always asked for every procedure to rate the technology compared with wire-guided localization. Was it worse, neutral, better, or much better? 94% of procedures, the radiologists reported or rated the technology as better or much better than wire-guided localization. The surgeon reported the technology to be better than wire in 99% of cases. Then we asked our radiologists who utilize all the 3 radiation-free technologies to rate these technologies. Again, on a scale from 0 to 10, with 5 being equal to wire. So the neutral point is 5, because that is a gold standard, has been. And the mean rating for SAVIS-CAT was 8 out of 10. 10 was considered to be the ideal marker, which does not exist. This was followed by MAGSEED being 7 out of 10. Localizer was least favorable among radiologists with a score of 5.2, almost equal to that of wire-guided localization. I think that is mainly due to the fact that the localizer utilizes a wide bore needle, 12 gauge, which is very difficult to insert through the skin. It requires a small incision, and it's very difficult to push through very dense breast tissue. The surgeon rating was very similar to the radiologist rating, 8, 7, and 6, with service count being the best and all technologies being better than was. Then we carried out a pooled analysis of the literature, including our experience, spanning 842 cases. The overall, and this is the pooled estimate, if successful deployment was almost 100%, successful retrieval was almost 100%. In 4 studies published in the literature, which looked at the re-excision margins in patients having service count and in patients having wide-eyed localization, the pooled analysis that we carried out showed a 40% reduction in re-excision rates, from 21% to almost 13%, and that was statistically significant. Now, the next few images are related to our clinical practice. And this is basically the control film in a patient who had breast cancer and had an implant. This is the marker deployed at the time of biopsy, and this is the service count. So it's quite a pretty image. Can't go to the next slide for some reason. Here we are. This is a specimen mammogram for a patient who had a small cancer. This patient came from abroad, so they already had a marker clip deployed here. This is service count deployed next to the tumor, and surgical excision was complete and fast. The patient had clear surgical margins. This slide demonstrates the MRI artifacts related to the use of service count. You can see here, very, very tiny artifact. In this particular case was 4.6 millimeters. This is another image here. So therefore, we can use it in patient undergoing neoadjuvant chemotherapy after deployment at the time of biopsy. This is a patient who presented with pathological lymph nodes. Here you can see abnormal lymph node with high blood flow. So at the time of diagnosis, we deployed service count marker here in the lymph node. And then she had neoadjuvant chemotherapy and immunotherapy. And during follow-up, you can see the tumor shrank substantially. And this is the service count here in the center of the lymph node. Easy to visualize on ultrasonography. And we did targeted axial dissection for this patient, in fact, last week, and the lymph node was normal. In other words, she achieved pathological complete response. This is a picture of the lymph node specimen radiograph. This is a lymph node, and this is a service count. So it's very important to note that the service count does not need to be embedded completely within the lymph node. You only need to insert part of it in the lymph node, and that doesn't really move from position, we have observed. So migration extremely low, and we think this is an advantage of service counts compared with other technologies. So in conclusion, service count localization is effective and reliable alternative to wire localization, at least non-inferior. The time efficiency improvement in both radiology and operating room have been proven. And there is a very high acceptance by surgeon, radiologists, and patients. Service count is currently our preferred method for wire-free, radiation-free localization of non-palpable breast lesions. The minimal MRI artifacts and resistance to migration and low re-excision rates support our choice. What are the future directions? Are there studies that may be required to improve service count. We believe that there is a need for randomized control trials comparing these three wire-free, radiation-free technologies head-to-head. We no longer believe we should spend too much time and costs on comparing this with wires. We believe that the advantages are very clear, but it would be worthwhile looking at other technologies and compare them head-to-head. We believe that the addition of capacitors to the reflector would enhance resistance to electrocautery and reduce the probability of deactivation. We also believe there is a need to develop MRI-compatible introducer needles so that we can deploy the reflector under MRI guidance. I'm aware of a colleague of mine who has deployed it under MRI guidance without any issues. But in theory, the introducer needle should be modified to be totally MRI compatible. We believe that the development of differently shaped reflectors, probably shorter in length, would help in bracketing procedures. The cost effectiveness should be included in a future analysis to be proven. We have calculated that the use service count results in $1,500 of savings, and that includes direct and indirect savings. However, this needs to be bona fide with future studies. We believe also the potential impact of service count in improving the aesthetic outcome should be studied in future analyses. The potential addition of energy to reflector to ablate locally tumors could be an exciting possibility in the future.
Thank you. Should I go through?
Yes, we have Professor Mokbel with us.
Thank you.
Yeah.
Thank you, Professor Mokbel. Thank you for your fantastic talk. I'm sure that service count in the able hands of yours is a very good tool. Is a fantastic tool, if I may say. I cannot see any questions from the audience, but does Mr. Mazanat or Dr. Franceschini have any comments or questions for Professor Mokbel?
I think it's very interesting talk. It's great to see Prof. Mokbel speaking about his experience with the service count. We have used lots of the localizer till now. I think we're on nearly 200 cases now, and we are trying also MagSeed because I think there is benefits from each of them, and it's great to see that they've already compared all three together. The only thing that I find slightly interesting is that I think that because of the size of the localizer, that the radiologists will not be as liking it as much as MagSeed and the service count because of the size of the needle, and because the difficulty sometimes they have putting it where they want it to be. So most of the time we'll find it on the side of the tumor, not in the middle of the tumor because of the size of it. And the other thing is that sometimes it does move a bit, and I'm sure that Rob will talk about a couple of things with that. But I was a bit surprised to see that, for example, the surgeons preferred, for example, MagSeed over the localizer. Till now, we are using the MagSeed and the localizer, and some of my colleagues do prefer the localizer probe because it's quite nice, small, and easy to use compared to the MagSeed probe. But those are just variations between individuals. It's very difficult to gauge things. Any comments about that from Prof. Mokbel?
Yeah, thank you very much, Yazan, and it's a real pleasure to be with you. Yes, I think that, yes, you're right. I think the localizer has an attractive design of probe and detector. And when we saw it first, we were so impressed. We thought this is going to be the way forward. I think when it comes to practical issues, we have found, apart from the radiologist feedback, that this is more difficult to deploy through dense tissue. They always needed to make a small incision, etc. We also found that there is an incidence of migration of the localizer chip or tag up the needle track, because the needle track is quite wide. And in fact, I do have images demonstrating that between the control film and the specimen radiograph. So we had cases where the radiologist put the tag right in the middle of the tumor, and then we did the specimen radiograph, and we found it is actually moved about 1 centimeter out of the tumor up the migration tract, because the tract is wide. And also the other issue is the MRI really artifacts are the main reason that drove us really to choose the SAVI-SCOUT, because nowadays we deploy it at the time of biopsy for all come out lesions. For example, U5 lesions, or when we are confident of the diagnosis of malignancy, we deploy it at the same time. We no longer use a marker clip. And so the patient needs, for example, like adjuvant chemotherapy or MRI after the biopsy, then the artifacts are not going to be an issue. I think we have the localizer was the second device that we evaluated, and we provided a report to Hologic, and we recommended a few modifications to make the needle holder, needle introducer narrower in diameter, and reduce the artifacts and so on. Unfortunately, that hasn't happened yet, and I think they have modified it. They added, I think, silicone sheathing to actually make it slip more easy through the tissue. So that is a development. I think the glass casing also can be an issue. It does increase the MRI artifacts, and we had not in our center, but in a neighboring center, a case where there was a fracture of the glass and it was difficult to retrieve afterwards. So I think, yes, I think each of them has advantages. I expect, I think, particularly in surgeons who work in multiple hospitals, I think the localizer can have an advantage because the surgeon can carry out the device. I think the Maxine, again, the issues we had with it was mainly facts generated by the MRI reflected. So we did evaluation of the three, and we went into it in an open mind, and we looked at the feedback and the analysis, and we decided to decide that for practical reasons.
It's great to hear that feedback, because I think we are heading towards the same route of evaluating at least 3 of them before deciding. Though we used the localizer for about 200 cases, mainly because we had to operate off-site on a different hospital. So it wasn't logistically possible to use the others. We needed that little, the flexibility of that little probe to go to the other hospital to do the operations.
In fact, we carried out 3 meta-analyses of SAVI-SCOUT, localizer, and Maxine. To be honest, they are all very effective technologies. I mean, we didn't really find any issues at all. I think what we're talking about, some probably practical differences that may make a surgeon or a radiologist prefer one over the other. But the 3 technologies, according to the 3-fold analysis we carried out and they've been published in literature, they are all very effective and at least non-inferior to WAS, and they have the advantages we have highlighted.
Thank you, Prof. Gianluca, any questions or comments from you?
May I ask a question to Professor Mokbel? Thank you very much for your very thorough presentation. I would like to ask you if your neoadjuvant pathway has changed. You're putting in the lymph nodes after the biopsy, the SAVI-SCOUT or the standard CLAPE, in order to have these lymph nodes for TAD?
Nowadays, we deploy a SAVI-SCOUT in clearly pathological lymph nodes. Mm-hmm. I think partly because we would like to avoid a second procedure, and also partly that the marker clips can be very difficult to visualize after a response to neoadjuvant chemotherapy. I think what we recommend, if one to use a marker clip, we would use the hydrogel marker because we think that is more easily visible on the sonography. But in general, we have carried out a large number of target dissection, about probably 30 cases so far, which is the numbers are increasing. And again, we found the technique really very practical, very easy, as simple as doing sentinel lymph node biopsy. Just go with the probe and identify the signal and remove the lesion. I think some of the issues I mentioned in my last slide have been addressed. We did provide feedback about the capacitors, and the new reflector being used now has 2 additional capacitors. So it is quite resistant to electrocautery. I think the only potential disadvantage of SAVISCOUT, in my opinion, is inactivation by electrocautery. So the original version, so if you become very close with electrocautery, you lose the signal. And however, by that time, you know exactly where you are, you've already decided your excision, etc., if that happens. But the new reflector is very resistant. And I had a case, in fact, yesterday, I had to put the diathermy right on the reflector to inactivate it. Yes, so basically for targeted dissection, it is very easy to use and very pragmatic. And yes, we tend to use it at the time of biopsy if the lymph node is clearly pathological.
Okay, and you haven't experienced any deactivation by being in less than 2 millimeters touching the probe? I mean, the SAVISCOUT touching the probe.
I mean, I think with the new reflector,
there's no problem. Okay.
The original version, we did have inactivations as we're doing the dissection, but we've already found out where and identified where the SAVISCOUT reflector is. And because we use electrocautery to remove the tumor, so in a few cases, we did find that by the time we dissected it and cut it out, that it was the signal may have been lost. But with the new reflector, we haven't seen that. We've only seen that the new reflector, and we're doing that as part of our research program. Only really when I touch it with that diathermy. I mean, yesterday I was 2-3 millimeters away, and so the signal is there. And this is after removing the specimen. So I only touched the reflector to actually inactivate it. So I think the new device has overcome many of the initial limitations, in my opinion, and it is more reliable.
Another question, Professor Mokbel. I would like to ask, the cost is an important consideration of the evaluation by institutions. Is it covered by insurance companies, or patients have to pay out of pocket for SAVISCOUT?
In the UK now, it has been accepted by all medical insurers. And we were in fact the first center to use in the private sector. And initially they raised some questions. They were worried that this is a new sort of kind of treatment. But when we explained the advantages to them, and we sent them actually the first publications we had, which was a meta-analysis, and now all insurers in the UK cover it without any issues because they realize the advantages. I think if you carry out cost-effective analysis, including direct and indirect savings, it is very clear that it is very cost-effective. In the UK, you know, for example, in the private sector, to deploy a market clip, for example, the medical institution, Sharp Insurance Company, £1,700 just to deploy a market clip. When we explain to them that we can avoid doing 2 procedures, so if you insert a wire, for example, let's say a patient who has breast cancer, you deploy a standard titanium market clip. The cost of that £1,700 to the insurer. Then, when you carry out the surgery, you will deploy a wire. There's another £1,750 to the insurer. So we explain to the insurers that you know, you can save that. You only do 1 procedure, and they found that very attractive. And the capital costs are not substantial. I mean, the the device is about probably $20,000 to $25,000, the actual detection system. Again, when you look at the indirect savings in relation to radiology suite efficiency, operating room efficiency, and potential reduction in the operations that is confirmed, then and avoidance of second conforming procedure from the time of biopsy, I think it is clearly very cost effective, and potentially one can save on average $1,500. The problem is to sell that argument to the insurers can be quite difficult, but we were quite successful in the UK, and that is now happening very smoothly.
Okay, thank you very much. We have some problems having Professor Franceschini. Will sort it out.
Sorry, maybe now you can hear me?
Now we can hear you, yes.
Oh,
yes.
okay. Sorry. So thank you, Professor Mokbel. I have just a little question for you. So the possibility of being implanted so long before surgery during the biopsy with a little discomfort for the patients and the compatibility of this tool with MRI, I think that makes this tool absolutely preferable in patients who are candidates for neoadjuvant chemotherapy. So I just want to ask you if you have experienced these tools in that patients.
Sorry, what's the question? Sorry, I didn't get that.
Oh, if you used these tools in patients who are candidates for a neoadjuvant chemotherapy.
Yes, that is actually standard. I mean, as I said, all patients undergoing potentially adjuvant chemotherapy, they have the reflector deployed at the time of biopsy in the primary tumor and in any pathological lymph nodes. And then we only see them at the end of treatment. We carry out MRI, post-treatment MRI prior to surgery. And the longest, in fact, the duration we had was 210 days. The patient who had the adjuvant chemotherapy and had further delay in treatment, and she had Satis count in the breast and the axilla, and there was no issues at all.
Okay, thank you.
Okay, if we have no other questions for Professor Mokbel, we would like to thank him. It was a great honor having him in our webinar. Thank you very much for your thorough presentation. Let's move on to our next speaker. Our next speaker is Andreas Karkatsanis. Andreas is a chief breast surgeon at the Uppsala University Hospital. He's very experienced in using MACTRACE and MACSeed. He was the first author of the Nordic CENTIMAC trial. His presentations are always interesting. So, Andreas, the floor is yours to dazzle us.
Thank you very much. Thank you very much for the invitation. It is always special to come back home, even virtually this time. So I will just share my screen and go through this roller coaster of several things that we would need to discuss. I have not called my presentation "The Future is Paramagnetic." I just thought that I would give you a summary of how the data looks like, but also what we have been doing here. I hope that everybody sees it very clearly. So these are my conflicts of interest. The most substantial conflict of interest, though, is that I am working with completely off-the-label uses with the magnetic technique. So we know how the background looks like. The majority of lesions are nowadays screen detected. With the data from the pivotal trials and the introduction of primary systemic treatment, most of our patients are no longer upfront axillary lymph node dissection candidates for any reason. So we need some way to localize the lesion in the breast. Most of the times we will need to localize something in the axilla where the data is still a mess and it is an evolving landscape with new things coming every day. So the quest for new ideas is always on. And
Andreas, sorry, can you go full screen if you may want to go full screen?
I think I have. I see myself as full screen here.
Okay, because I think I can't, but I'm sorry to interrupt.
Let me.
So, Andreas, we only see your first slide.
Okay.
Costas, we can only see. So I think you're describing your third slide, the background. We can only see. I think most of us is that what everybody's seeing. We are seeing your first slide with the time.
Okay. I'll just stop sharing and start again then. So let's try to do it one more time. And yep. How is it now?
It's good.
Yep.
It's good.
Okay, fantastic. So what do we need from a novel tracer? Well, what we need is, we are talking about non-inferiority, which is a methodological term, but in reality, we need new techniques to make our life easier and to give us a wider frame for implementations. We need to make things meet and serve modern patient needs. So the idea with that is that we would have to discuss in a principle, so to say. So the magnetic technique has to do with both with the breast and the axilla. And intuitively, I'll just put it like MagSeed and MagTrace, despite the fact that I have used other techniques and other tracers too. So I'm not really, exclusive to something like that. But we are talking about a 5mm paramagnetic seed, and we are talking about super paramagnetic iron oxide nanoparticles. And why do I do them? Well, I do them because I do not depend on nuclear medicine facilities, rarely anymore, however. I do some of the localization myself, having some skills with the ultrasound. Everybody's happier because of the detachment of localization procedure with the OR schedule, and patients are happier because they don't need to do the mini tour through nuclear medicine and get a wire sticking out of their breast and so on. And moreover, I have some outside the box implementations that we will be talking about. So keep these slides in mind. This is the standard process nowadays. We meet the patient, we plan surgery, nothing happens until the day of surgery, and on the day of surgery or the day before, there is a panic, trying to localize the lesion, trying to inject the isotope, and so on and so on. So SPIO can modify this procedure, and because it has got a wide time frame of preoperative injection, as I will be showing. And MagSeed has the same potential. So this is something that we will be discussing and building on. So what is the data out there? This is a proffered paper from SO45 that we did with people from the Marsden Eyebrow University and Navarra Clinica in Madrid. And we did a systematic review and meta-analysis using the grade recommendations to see how things are out there. So we thought that we would see SPIO outcomes as a sentinel lymph node tracers and what the concerns are. So what we saw in some 3,600 patients is that the detection rate is completely comparable. The nodal retrieval is slightly higher, but with some heterogeneity, as you see there. And the procedure is highly concordant to what the radioisotope with a blue dye would detect. Going into only the comparative studies, we performed subgroup analysis and meta-regression to see if there is any particular profile that makes the SPIO more effective than the isotope and the blue dye. And in meta-regression analysis, a preoperative injection and the setting of delayed sentinel lymph node biopsy, the sentinel procedure that we will be talking about shortly, showed that SPIO had a favorable profile in this setting. Neoadjuvant chemotherapy does not affect the performance of SPIO, neither metastasis in the sentinel lymph node. About the staining in the MRI, because these are the concerns, the data over there is very, very controversial because the quality of the studies is low. But the thing is that there are MRI artifacts if you inject and do not remove the injected area. And there is skin staining, especially if you inject close to the skin or subareolarly. So the factors for that is the breast conserving surgery, subareolar injection, preoperative injection, and the higher dose. This means that in this analysis, we have a profile that suggests that SPIO given in a lower dose and close to the tumor addresses these problems. But since the grade of recommendations is very low, I'm keeping myself a little bit conservative. So the conclusions is that it is both clinically but also methodologically non-inferior in the upfront setting. It is probably superior when we are doing sentinel lymph node dissection, and I'm saying probably because there is only one trial out there, the trial that we did here in Uppsala, and the optimal profile of the method is a small dose, peritumoral and preoperative, which is also in line with preclinical data that suggests that SPIO concentration will yield a plateau at least 24 hours after injection. So the research priorities, according to the grade recommendation, is to seek studies with higher level of evidence, to define an optimal dose, and to investigate the efficacy of the technique in delayed sentinel lymph node dissection, not only in DCIS, but also in the setting of primary systemic therapy. Going further to the SEED, well, we know that it is safe, we know that it is accurate, we know that it does not migrate, it is detectable in any depth of the breast because you can go from different angles, and it is easy to retrieve. These are data that come from feasibility studies, but also from a pooled analysis from the group of Professor Mokbel. So more or less, these things are solved by the literature. When looking into wire versus seed, there are two trials, one by Kostas Zachariadakis and one from Katerina Micha, both from the United Kingdom, that suggest that we have comparable re-excision and retrieval rates, patient experience is enhanced, physicians are happier with that, and that we do not remove excess tissue with the technique, which is also important because it is in line with the concept of precision and accuracy surgery. And it has also been used for the marking of axillary sentinel lymph nodes. I've got some data in my back pocket about that for the magnetic TAD, and we will perhaps discuss it a little bit later. So what are the challenges for breast surgeons? Well, the things that are difficult, they are very intuitive to understand, but difficult to measure in clinical routine is logistics, is what we do in cases like sentinel lymph node dissection and DCIS, recurrent breast cancer, in the axilla post-neoadjuvant, in the setting of complex oncoplastic surgery, and how to utilize everything to make things work easier for us. And well, the minimal invasive sentinel lymph node mapping is a dream of mine that I think we should come back to and look into, because what we need diagnostics. If we can kind of do it without surgery, I think that we would all be happier, mostly our patients. So sentinel lymph node in DCIS, well, don't do it. It should not be performed. This is a study that we published in the BJS this summer, which showed that all the national and international guidelines that have a specific recommendation have the accuracy of the toss of the coin. So it's a 50-50 if you follow the guidelines, and it does not get better regardless of what your preference criteria are. So what we came up with is that we try to take advantage of the property that SPIO has, that it kind of stays in the tissue for a longer period, and, you know, flip it. So we injected the SPIO in the breast when we were doing the DCIS operation, but we were not removing any sentinel lymph node. And if pathology showed invasion, then we would go back. We've got a published interim analysis and an ongoing RCT right now, and it looks like that. The first study is something that we interrupted prematurely because we reached the primary endpoint quite early, and we saw, comparing it to the very detailed Swedish registry, that the implementation on a national level would have a beneficial effect. And a little upgrade is that when we have applied this technique, then we can not only discuss avoiding sentinel lymph node dissection and pure DCIS, but we can discuss the cases of low-risk tumors and microinvasive tumors where the literature starts to trend towards omitting axillary dissection or axillary mapping overall if risk factors are not there. So when we worked at Preoperation, SPIO outperformed technetium both in terms of detection rates and nodal yield. And what is the catch? Well, the catch is that while it is feasible to perform sentinel lymph node dissection in a breast that has been reconstructed with a DA 1 month later, I would not suggest to start with it if you don't have experience with the technique. And this is what is summarized in this slide. Something which is not so unexpected. Well, the nodal yield and the accuracy of the procedure of doing sentinel node 2 or 3 weeks or 1 month after breast conservation is challenged. And pathophysiologically, this is very intuitive to understand. So to sum up things, in the sentinel study, we had approximately 80% of patients that were recruited that finally avoided upfront sentinel lymph node dissection. It was actually cheaper to include in the study than do routine cases. And the sentinel results stimulated us to go further in order to understand a little bit what happens with the accuracy of the procedure. The ongoing trial is separately designed for mastectomy and breast conservation. And we are happy to discuss recruitment. We've got already people from 4 different countries. The next case is that dream of mine about not performing surgery for invasive breast cancer. So to change sentinel lymph node dissection to sentinel lymph node biopsy and perform a magnetic guided axillary ultrasound, what we call the Magus technique. And we recently published a phase 2 trial on that. Magus in a nutshell looks like that. We use the SPIO as contrast for the axilla, and we perform an MRI lymphography after we have injected the SPIO. With the help of these images, the radiologist performs a secondary ultrasound, and with the help of the probe and the detection of transcutaneous signal, we take a biopsy. The corneal biopsy is checked for magnetic signal or brown color, and back at surgery, we see whether the node was biopsied or if there were more sentinel lymph nodes. And it is quite intuitive. It looks like that, before and after the core biopsy and the specimen. This is the flowchart of the trial. And well, to sum things up, we saw that Magus had comparable predictive ability with the sentinel lymph node biopsy, while it outperformed axillary ultrasound that we standard routinely use. You see the specificity and sensitivity as well as the accuracy of the procedure here. To make things a little clearer, well, the case of a lady that is obese, where the ultrasound is a very, very challenging and limited accuracy modality. So here you've got a sentinel node that has uptake, which is very homogeneous, but a little bit higher up, you've got this. And when you go on a focus ultrasound, you see what you would have probably missed in this bulk of fatty tissue. In surgery, we had 2 sentinel nodes, out of which 1 with macrometastasis. We have expanded this concept in the setting of neoadjuvant treatment, in primary systemic treatment, because the idea of false negatives accounts both for the fibrotic changes, but also for the normal remodeling effect of the lymphatics that we all know of. So we were discussing whether mapping the axilla in such a manner prior to sentinel lymph node biopsy that you would do after neoadjuvant could kind of help us perform more accurate mapping and discuss whether it could reduce false negative rates or allow for tailored treatment while we are still waiting for the Energy B51 and the Alliance 11202 trials. So this is a lady that underwent neoadjuvant treatment. This is her baseline MRI lymphography, where you see 4 lymph nodes before the induction of primary systemic treatment. This is the dominant node, and this is the mammogram that shows a clip in the breast and a clip in one of the nodes in the axilla. But mind you, we know that this is a sentinel node. It has been biopsied. So 4 months later, you still see the same topography, the same 3. I took the exact slices so as to make it clear. And then we went to surgery. We had 4 sentinel lymph nodes, 1 of which clipped, and YPN0. In the Magus trial, the patients that were in this subset had, very interestingly, no radiologic migration, which means that SPIO remained for these months on the correct nodes, on the nodes that we would have detected from the very beginning. And this is very relevant because it suggests that there is more to this procedure to capitalize on. We were talking about the standard process. I will just remind you that. And we said that the SPIO modifies the process, but also the MAG seed. So the intuitive thing is to do both. And in line with that, we introduced a concept that we call the MAG total, where we are putting the MAG seed in the tumor. We are trying to put it half in the tumor and the other half protruding from the anterior margin of the tumor. And then we delineate the perimeter of the tumor or the dorsal area of the tumor with MAG trace. This allows for a completely magnetic technique that helps us not only enhance the signal in the case of the larger breast where the 4 centimeter detection zone is no longer an issue, but also it gives you a platform that facilitates logistics in a very, very intuitive manner. So this is the technique in application. This is a lady that's got a tumor that was screening detected. She came to the clinic. This is performed by a surgeon. This is something that I performed myself 1 week before surgery. We inject SPO behind the tumor. We put the MAG seed ventrally to the tumor. This is how it looks when we send it for a mammogram. And then this is how the specimen looks like. And this is how her brown sentinel lymph node looks like. So in a pilot that we published at the EJSO some years ago, we saw that this is a localization procedure that is integral and very easy. We had negative margins, but we had very small resection specimens. And the sentinel lymph node detection was successful. It was easier for logistics and easier for all involved physicians and all people that are planning surgery. And this is what we saw in a PREMS questionnaire. We nowadays are completing a multi-center randomized control trial on this issue, and we are expecting results anytime after the new year. Speaking to surgeons, I mean, it's very important to discuss data and meta-analysis and everything. But what is very, very important for us surgeons is to have a technique that we can shape to what we need for our patients. So this is something that we recently presented at the ESO as a proffered paper, and this is a combination of MAG trace and MAG seed in order to make things work at the best manner for our patients. And these are patients that underwent massive breast conserving surgery with very acceptable results and very good prompts in the end. So this is the case that you've got a big DCIS in the breast and you mark the perimeter just with MAG trace droplets. And this is how it looks afterwards. This lady went for a delayed sentinel lymph node biopsy, but that was not a problem because we had already used the MAG trace in order to tattoo the sentinel lymph node. This is a lady with a very big pleomorphic invasive lobular cancer with wish for breast conservation. The strategic placement of 3 MAG seeds allowed for the delineation of the tumor, and we completed with droplets of MAG trace medially, and this is how the specimen looked like, and this is how the breast looks like. Combining MAG seed and MAG trace is another thing. This is a lady that underwent flap reconstruction. That the invasive tumor in the middle of the area of the DCIS was marked with the MAG seed, and the perimeter was done with the MAG trace. And this is how the specimen looks like, and this is how the lady looks like after surgery. Or the case of doing again only MAG trace localization in a lady with a very big DCIS and a very small breast. And again, this is how the results look like. The concept of neomagus that we were discussing about. This is the case of the lady with a 3 centimeter triple negative breast cancer. This is her BIRADS3 sentinel lymph node that was biopsied and was found negative. It was, however, clipped, and we went back. The tumor had good response. The lady underwent surgery. And you could fuse the technique. So this is a lady that where we used MAG trace and MAG seed to localize the tumor and to also perform delayed sentinel lymph node biopsy in the setting of neoadjuvant treatment. And it was still a quite challenging resection that we fixed with the help of a perforator flap. But the thing is that everything is very easy and practical because you do it in one platform. You use one and the same probe, both for the axilla and the breast. And it has to do with a technique that you could implement yourself. What next? Well, we need to be looking into how extended is the extended time frame, and how things look for the magnetic TAD, as well as standardizing of all these off-label indications. I am very, very interested and engaged in that, because I think that what these new wireless techniques have to offer is a frame for us to operate on in order to be able to provide tailored approaches for each patient. Having said that, I am pretty sure that we would need to surpass the traditional methodological difficulties of randomized controlled trials, either by means of network meta-analysis, which can address all the problems that traditional meta-analysis or pooled analysis have, as well as large collaboratives like those that are currently undergoing in the UK. I will leave it here from now. I will leave the TAD, the magnetic TAD part to Konstantinos, and I've got some slides in the back pocket if we need to discuss more data on the magnetic TAD. Thank you very much for your attention.
Thank you, Andreas. You have impressed us. We heard the person who has studied in depth MagTrace and MagSeed. Any questions? No questions from the audience, but may I ask Yazan Masana, Dr. Masana, if he has any comments or questions for Andreas?
Fascinating talk as usual, Andreas, and you know, this is the first time I hear lots of the things that fantastic things that you do, and it's great to see that somebody has taken a technique and pushed the boundaries and did lots of things with it. I remember when I was in Guy's, which is years ago, when Michalis was there and Theo was there, and it was the Sentimag trial, and Mike Dueck was using the Sentimag to do the sentinel node biopsies. There was a little observation at that stage that we were harvesting a bit more than what you would harvest for a normal traditional sentinel node biopsy if you do only a technetium and a blue dye. Are you still seeing that with the SPEO and with the new contrast, or are things different now?
So this is a very interesting and relevant question. This is something that we have seen in the meta-analysis, but also in a recent study that one of our PhD students completed. Long story short, most of the first trials had a very unclear protocol regarding what to do about palpable lymph nodes, and you know that most surgeons are not compliant people, you know that. So I can easily guess, without being there when you were doing the trial, that when one of your consultants was a little bit impatient, they took everything and they just counted the nodes ex vivo. This is something that is the explanation. The other thing is that when you inject MagTrace and massage it, and then go in the axilla to try and find a sentinel lymph node, you have not allowed for two things. You have not allowed for uploading the sentinel lymph node with the amount of SPEO that will give you a brown color and a high signal, and you have not allowed for enough time so that the SPEO in the lymphatics will disappear. This means that you have a much more diffuse magnetic signal in the axilla, which, together with inexperience with the technique, motivates resecting more nodes. When we were doing the MONOS trial, which is until now the only comparative pragmatic trial between the magnetic technique and the isotope, we did not see that at all. And this is something that we have not seen also when we are doing surgery in women that have received MagTrace preoperatively, because then it really works as a double tracer, because you do have the time to see this very, very characteristic brown color in the node. That's the one thing. And the other thing is that the magnetic signal is really focused on the node and not in the background when you're performing surgery in this setting.
Thank you, Andreas. I don't know if I'm heard. Prof. Mokbel has a question.
Yes, thank you very much. Congratulations on your excellent work and the presentation. I'm just likely to raise one potential limitation here. because I have seen my colleagues using this approach for delayed sentinel node biopsy following mastectomy for DCIS. I think here the caution should be exercised when dealing with extensive high-grade DCIS, because the upper grade in pathology has limitations. Unless the pathologist really examines every 1 millimeter of the extensive lesion, it is quite possible to miss occult invasive cancer. And we know from clinical experience that some of these patients who have extensive high-grade DCIS in particular, they can be node positive. I'm just wondering whether you would recommend special pathological analysis in the context of delayed sentinel lymph node biopsy in women, for example, having mastectomy with high-grade DCIS. Obviously, there are advantages. If you have low-grade DCIS and there's no upgrade, of course, avoiding sentinel lymph node biopsy can be advantageous.
So this is a very sensible thought. This is a thought that we had back in 2015 when we were doing the first cases in the trial, and this is the reason for which women that do not have axillary evaluation in this setting are registered in a different registry in order to see whether there is a difference in local recurrence and survival. Until now, we have not had any recurrences, but apart from our small sample, because I mean, a trial is just a trial, I will refer to data from the team of Steve Narrod from JAMA Oncology, where they have shown that axillary dissection in the setting, axillary mapping as a concept in the setting of DCIS has not been able to show any beneficial effect in survival. I would not do any particular pathology. I would not discuss the setting of changing things. I think, however, that this is a very, very clear way to go for people that know how to use the technique. I said it myself previously, that while I am supposedly a proponent of the technique, since this is something that has come within our group and from my personal research, I would not be very enthusiastic in telling somebody that have never used the magnetic technique, go on, do it after a mastectomy if you have never done it before. So we need to be very, very realistic. At the same time, when the pathology is concerned, if you inject the MAG trace where the DCIS is, the pathologist has an enhanced background and they report that they find it easier to find microinvasion or small tumors. This is not something that I can verify and start telling people, do that because you're going to get better pathology. This is an observation. The Sentinel 2.0 trial, which is ongoing, has already recruited some 500 patients, and we are going for 2,200 patients. So all patients are registered in a parallel registry. These are outcomes, and I hope that we will have robust data in a few years, because there is no other similar ongoing multi-center randomized controlled trial right now on this subject.
Thank you very much.
Thank you, Andreas. Gianluca, any comments from your part?
Yes, I just want to thank Professor Karagatsani. So this is a very
excuse me, I'm not a professor.
Oh, okay, doctor. This is a very interesting window on the future of breast surgery, and I have just a question about the problem. I read about the problem of skin discoloration, which, if I correctly remember, concerned about 1/3 of patients at 3 months. So I have just the curiosity of what about after much more time?
Well, actually, it is not 1/3 of cases. It is higher, but it depends. Okay. On, you see, the pathophysiology behind that is as follows. No matter how much iron you inject to the breast, it is only 2 to 3% that will migrate to the axilla. So this 2 to 3% is not heavily required in order to detect the sentinel node, which makes it crucial to come down to a smaller and smaller dose. When the discoloration rates from the first trials was unfortunately very, very underreported. It was only Isabel Rubio, Matteo Gili, Antonio Pineiro, and ourselves that mentioned it. And it was actually our group with the Nordic trial that did a 2-year follow-up of that. Subsequently, we have been looking into discoloration, and what we know now from both from this meta-analysis, but also from individual patient data meta-analysis that we are doing from the Nordic and the Centidos trial, is that 1 milliliter of peritumoral injection comes with a discoloration that is no higher than 2.6%, and we have a 3-year follow-up for that. In this particular population of patients that were followed after participation in clinical trial and received both isotope and blue dye as comparison, the blue dye staining in these patients was 3 times higher. So the idea is that we need to move, is what I wrote in the slide of the meta-analysis results for the SPIO, that we need to move to a smaller dose and absolutely to a peritumoral injection. There is no question about that. And we need to be very, very vocal and very, very clear with the patient about that. My concern, which has been a concern for many, especially from the States, about doing postoperative MRI and so on, and how does that, how will that work, is something that we are also looking into through a prospective clinical trial that we have here, the post-MAG MRI trial. But I can tell you that if you remove it, then it's not there anymore, and then you don't get any artifacts. It's as simple as that.
Thank you.
Can I ask one last question? I know that there's we're a bit behind with time, but am I okay to ask a question for Andreas? It's great to see that you're trying to avoid surgery, sentinel node biopsies, even on patients with invasive disease, which is very much like the microbubbles technique that they used in Maidstone. You're using the iron-based tracer to identify the nodes using an ultrasound scan and then take biopsies from them. The question, will you biopsy 1 or 2, or will you biopsy everything that takes that? And the second question, what if it is positive? Have you really saved the axilla, or are you going to commit to a clearance?
Well, it is like that. You biopsy the place where you have transcutaneous signal, because this is the place where you would do your incision to begin with. Okay. That's the idea, more or less. What we are looking into is 2 things. If one looks into the initially positive axilla, you do have the possibility with this technique, as you would have with the microbubbles, to differentiate the patients that have non-sentinel lymph node metastasis from the beginning, which will have more advanced nodal stage disease, or if you have a too good a radiologist that will detect the only sentinel node that is metastatic, and then you go to surgery and then you remove 30 nodes and you've got 1 metastasis. And I mean, I'm not very proud when I've got these things. But patients that had axillary disease on the Magus were by definition patients with low axillary burden, so they could undergo sentinel lymph node biopsy only. And this is something that we discussed with them. But clipping it at the same time allowed us to change the plan and go to neoadjuvant if we wanted to. So it kind of, you know, it gives you that particular group of patients that the axillary ultrasound cannot differentiate, because the axillary ultrasound, we know that it leads a majority of patients to, you know, express clearance, whereas we should not have done it. I think that it is one more possibility. Still, having said that, the Magus was a very, very, you know, rigid and well-regulated and conducted trial, because it was controlled step by step. And despite the fact that I did it, I have to say that it is a phase 2 trial, and I can treat it only as such. I cannot tell you, you know, forget sentinel lymph node dissection, do what I'm telling you. It's a little bit like that.
Okay, so thank you very much, Andreas, again for a very interesting presentation. Let's move on now to Rob Milligan. Robert Milligan is a consultant oncoplastic breast surgeon at the Queen Elizabeth Hospital in Gateshead. He was the first surgeon in the United Kingdom to introduce the radiofrequency identification tags. He sits on the Eyebrow Committee for the breast lesion localization study, and he teaches internationally on this subject. Rob, we're happy to have you here with us today, and we're all ears.
Thanks for having me. I'll just share my screen there. Can you see that?
Yes.
Perfect, excellent. Well, thanks ever so much for having me. The title of the talk is RFID is the easiest way to guide breast surgery, and the answer is, I don't know. So thank you for listening. The content today, we're going to look at why we don't use guide wires. That's been covered already by Professor Mogbow, really, but we'll have a quick look at that. The Hologic Localizer wire-free guidance system, and a summary of our experience and results, and any lessons learned or tips for using the technique. So we know now that other techniques are better than wires, and the main advantage of this is decoupling surgery from the localization, and that has benefits to the surgeon, the radiologist, the pathologist, the trust, and the patient. So we know whatever technique we use, everyone's saying the same things, that ultimately moving away from guide wires is really positive, and certainly surgically finding a more focal localization of the tumor is hugely advantageous, particularly with incision planning. A brief look at the sort of preoperative localization trends. This is how I feel we've moved over time, and where I think the RFID tags sit in this sort of process. So initially we've had guide wires, which for 40 odd years were the mainstay of how we managed impalpable breast lesions. And over the last 10 to 15 years, we've seen sort of real ramping up and speeding up of the new technologies that are available. So the roll technique, injecting technetium around the tumor, never really decoupled surgery from the localization. Putting that radioactivity into a seed with the iodine seed was really a big move towards where we are today. But as has been mentioned before, I think in every country, the regulations around using radioactivity in a concealed source are huge. And I think if the system's set up, it tends to work well, but it's hugely laborious to start with. And if you lose a seed, certainly in the UK, it's a massive issue, and you have to stop your service for a while. It's a huge issue in a diagnostic setting. Then the next sort of phase, the fourth generation for me, is removing the radioactivity from those seeds or tags. And really, I think this is where the mag seed, the Savvy Scout, the Pintuition from Sirius, and the Molly Surgical all sort of fit into this area, and hugely advantageous again over removing the radioactivity. And then where I think the radio frequency ID tags sit is just adding in the fact that there is some degree of intelligence to that. So these tags give you back some information, and they can store information there. Currently what they store is a unique ID tag, sort of a number, but that information could be anything. And I think that's what separates it from the other technologies available. But each have their pros and cons, and there certainly isn't an exhaustive list. I think what it does show is that currently we have a buyer's market, which is really positive. And we now have choice, which we've never had before. And I think if you were going to buy a car, you can't say the BMW is the best car, you have to get that. I think you choose your car that would suit the purposes of what you're doing. And I think it's exactly the same from here. So it's very positive for all of us involved. The tag itself is a passive 11 by 2 millimeter radio frequency ID tag, and it's preloaded into a 12 gauge delivery needle. It's non-radioactive radio frequency identification technology, and you get a unique ID tag for every tag that's inserted. And it's similar technology to that that's used in microchips to identify pets. So looking at the system, there's a handheld reader, which is what you see in the center of the screen there. and that can be used in a non-sterile purpose to put over the breast and identify where the tag is. And the circular part at the end will be where the tag is sort of identified, and you get a distance on the reader that tells you how far the tag is from that area. There's a 12 gauge delivery needle and the tag in the center of the picture, and connected into the handheld reader is a sterile probe, which is what we use in theatre once the handheld reader has been put into a sterile packet. The sterile probe is single use. So this is the size of it. It's very small, and I think that's one of the advantages compared to perhaps some of the other technologies, is the fact that it is a small, robust system. So as Yazan had said earlier, certainly during COVID, a lot of us were operating in different hospitals to our usual base hospital, and sometimes surgeons were operating across 2 hospitals, so there might be a list at your normal hospital and an operating list at the other hospital. So by having more of these units and being able to transport them easily was a huge advantage. The probe is comparable to a biro there, so very small. So for remote incision surgery, where if you're planning to operate in the periareolar kind of incisions or the perimeter of the breast, it's quite helpful to have a small, non-bulky probe. The cost, this is what everyone's interested in, and the cost for these is pretty competitive on the market. The readers are about £4,500 or UK pounds for the handheld reader, and they come with a warranty and they don't require any servicing. They're really robust. I think on about day 1 or day 2 of using this, one of our theatre staff dropped one on the floor, and they're a bit like a kid's radio. They just bounce and didn't cause any problems. I'm not suggesting you throw it around the operating theatre, but it certainly didn't smash or shatter. So that was kind of reassuring from our point of view. The consumables, so that is the insertion needle, the tag, and the sterile probe, cost about £270 per case. They're CE marked for insertion anytime preoperatively. And as we mentioned earlier, they come in a 12 gauge preloaded needle, which is slightly larger than the competitors. They're MRI safe, but as Professor Mockbrown mentioned, you get a 2 to 3 centimetre signal loss around the tag. So they're safe, but we tend not to use them. If patients are, if we know they're going to have an MRI scan, we tend to insert them at a later date. This is how the tag looks on ultrasound images at the top, sitting within a tumour, on mammograms, and then the final picture there on a specimen X-ray, which again, comparable to any of the other techniques that we've seen already today. So there's a reasonable amount of published literature on RFID tags, and stemming back about 10 years or so in America, when they first came up with the concept of this and inserted the tags into turkey breasts, and gradually sort of human experiments and research taken place removing benign lesions and cancers, and relatively small numbers in these, but all that showed that the technology was safe and could be used to identify non-palpable lesions. About a year ago, we wrote a paper, published a paper on the RFID tags and our experience since we introduced it in June 2019 in the UK. And ultimately, we showed that the system is safe. It's safe for our patients in the UK, and it was advantageous over guide wires where we'd switched, and we were very happy with the change. So we discussed all our histologies at the MDT meeting, and our guidelines at the time for removal of invasive and cancers and DCIS is 1 millimetre, and we performed further surgery where appropriate in the form of re-excision or mastectomy. We inserted 177 tags into 150 women, and the mean insertion time was 7 days preoperatively. The average age of patients for our breast cancer was 62 years, and the vast majority of these were screen detected cancers, as we'd expect. Only 4 of these lesions were inserted stereotactically. And I think that's something that we probably keep the number fairly low. I think even with guide wires, our radiologists were keen to localize with ultrasound where they could, either aiming for a VAB cavity or a clip if they'd had a previous biopsy. stereotactic with a guide wire is a bit advantageous, because when the breast's in the mammogram and the mammogram gets released, sometimes the guide wire can migrate and move away from the lesion as the breast recoils. And with a guide wire, or most hook wires, you have the advantage of being able to pull that out and reposition it. And one thing you have when you've inserted any of these tag technologies or seeds, once it's in, and if it's going to be removed, it can't just be pulled out. It needs an operation or something, BAE or something, to get the tag or seed removed. So we tend to avoid stereotactic insertion if we can. So we deployed our tags pretty much successfully to the targets. There were 3 that were misplaced. So Professor Mockbell had mentioned migration along the tract at the time of deployment. So early on in the process, one of our radiologists had put in a tag, and I think probably it's a technical thing why it removed back at the time. And I think if you're pushing the tag out once it's in the lesion as you retract the needle, I think that doesn't happen so much. Whereas if you kind of push the tag very quickly and then try and pull the needle out, I think it's more likely to get stuck and not fully leave the needle. So it needs to be a bit of a more gentle process. And we haven't really seen any further episodes since then. One tag was inserted a couple of centimeters anterior to a lesion, and the surgeon requested a guide wire in addition on the day. And one patient had a stereotactic localization. This was sort of at the lateral edge of a 4 centimeter area of calcification. So a second tag was inserted to bracket the lesion, which wasn't the plan preoperatively. There had been some reports from our radiologists with difficulty inserting the introducer into dense breast tissues and the center of very small or fine masses. And I think that is largely due to the size of the tags. It's a 12 gauge needle, which is significantly bigger than the competitors on the market. And the first thing we've said when we fed back to Hologic about the system is you need to make these smaller. And I think it is a disadvantage of it, there's no question. I think it's the main disadvantage. But has it affected us significantly in terms of how we go about the process and our resection margins and the size of specimens we take? I'd say no, it hasn't. I don't think it's a major issue, but I think we're at a very innovative time here, and we are evolving throughout, and we're seeing so many great evolutions, making our lives better and better for the patient. So I think we need to keep pushing and not accept that we've found the perfect solution yet, because I honestly don't believe we have. So all our tags were located and retrieved. On occasion, we noticed that the tags that were placed superficially within the breast were identified during the dissection. And this is something that we have seen from time to time. So I would say, from our point of view, if we've had tags that have been in superficial lesions, we tend to try and get our radiologists to localize them posteriorly on the lesion. And I think that can make a difference to reducing what you see in theatre. In terms of our results, the majority of patients had wide local excision surgery. There are a few mammoplasties and a few volume replacement procedures. The resection margins or re-excision rates, including mastectomies, was 8%, and there were no specific complications noted at the time. We'd used this for a handful of targeted axillary dissections and had no problems. In terms of targeting axillary lymph nodes, this is something that we've recently looked back at our practice on. And the pathway that we generally have when we're using tags is patients will get a diagnostic ultrasound scan. If it's benign, they will have a sentinel node biopsy. If they've had a biopsy and the area is malignant, they either go for a primary axillary node clearance, or more often these days, we would insert an RFID tag into the abnormal node and perform a targeted axillary dissection, particularly for the sort of not predicted to be responsive disease, like ER positive, HER2 negative disease. If there's low volume nodal disease, we tend to go for a primary targeted dissection. Some of those patients will have had a Hydromark clip placed, but not all of them do at the time of biopsy. If patients are going for neoadjuvant chemotherapy, they'll if they haven't had a hydromark clip placed, that will be placed in prior to neoadjuvant chemotherapy. And then at the end of treatment, patients will be reassessed for suitability for targeted dissection and have an RFID tag placed in at that time. So this is a thickened cortex of a metastatic lymph node. And this just shows the tag sitting within the node, and again, sitting within the node. And I think realistically, we're more likely to see this sort of picture with the tag fully in the node in those patients where we've localized early. So they're the primary sort of targeted dissection patients. Once patients have had a metastatic node that's had neoadjuvant chemotherapy, the sort of patients we put through neoadjuvant chemotherapy tend to have a very good or pathological complete response. So the nodes are often fibrosed and shriveled, and they're difficult to identify in theatre when we do an axillary clearance, and they're difficult to identify pathologically and sometimes radiologically as well. So really that's targeting the clip and sometimes the node when we go back after neoadjuvant chemotherapy. Similar to Professor Mockwell, we use a tag sheet, which allows the radiologist to show us where they've put the tag within the breast and to identify the tag site. So if they've had multiple tags, there's an area where you can write the tag ID number. So it's a unique 5-digit ID number. So you can identify which tumor or which part of the tumor you're picking up on the probe at any one time. And in contrast to some of the other techniques, I did a lot of work with the iodine seed in the past. And if you're doing a complex mammoplasty with several iodine seeds in the breast, there was times when it was confusing and you didn't know if you're picking up the signal from the first seed or the third seed. But there were times that it became a bit more difficult. And I think this is one of the big advantages for a select few cases of the RFID tag system. We place these tag sheets electronically via our system with the x-rays, so we can identify them in theatre, and it's reduced the paper trail on the day of surgery. In the days where patients would get a guide wire in, they'd take this packet back with them from the breast screening area. So by uploading them electronically, it saves us having to go and do our homework before the operation and pick up the tag sheet. So it has made life a bit easier for us. Also, they don't tend to get lost like the packets used to between radiology and surgery on the day of surgery. So looking at our results, we reviewed our practice from June 2019 to June 2021, and we'd inserted a total of 679 RFID tags in 578 women. 31 of these tags were inserted into axillary nodes in 31 women with a fairly wide age range. Now, that's not a huge number of targeted dissections over that period of time. And part of the issue there is that during COVID, we were advised in the UK that neoadjuvant chemotherapy generally wasn't an option for our patients. So we were very much into more aggressive surgery and axillary clearances at the time rather than targeted dissections. And patients with positive nodes, we were told to go straight for an axillary node clearance. So probably why we don't have a massive number of targeted dissections. 9 of the patients had their tags targeted to clipped metastatic nodes post-neoadjuvant chemotherapy. 19 were targeted to metastatic nodes in women who had a primary targeted dissection, and 2 were targeted for diagnostic purposes. All the tags and their respective nodes were successfully excised, and they're all confirmed in a histological report by tag site reaction. There were no reported cases of problems and complications with regard to tag insertion or retrieval, and we took an average of 4 nodes excised per case. There was a big range there from 1 to 17, but the most common was 2 lymph nodes. And that probably represents the patients who have had the primary dissections. In all expected cases, the metastatic nodes were retrieved. They're all macro mets. And in 7 cases, there were no mets identified. 5 of these were due to pathological complete response following neoadjuvant chemotherapy, and that was confirmed in the histology report. And 2 cases were benign nodes for diagnostic biopsy. 6 women went on to have completion clearances, and I think 3 of these were due to further disease identified at the the targeted dissection, and our current recommendations is to go back and perform an axillary node clearance. And I think the other 3 cases were due to more disease being identified upfront on the primary dissections than expected. So the ER positive, HER2 negative disease, where there are very big nodes or multiple nodes, extracapsular spread, and there was a thought there could be some further disease in the axilla, so they opted to have axillary clearances rather than radiotherapy. For those 6 cases who had axillary node clearances, we found a further 2 micrometastasis in 2 women. So probably not worth it overall. We've had a short learning curve. I think when you move from guide wires to a different technique, it can be a big change for the surgeons, but actually we've all been doing sentinel node biopsies for years now. And I think any of these technologies realistically are holding a probe and identifying a small area within a breast. I think it's very intuitive for all surgeons. So the learning curve is short. It's short for the radiologists, and the pathologists really like the fact that they don't have guide wires to deal with. Some guide wires can be very difficult to remove from the breast, and they're sharp, so it's made things a bit safer in the path lab as well. The feedback has been excellent from the patients, and surgically we've found having a unique ID to each tag has been quite useful for the more complex cases where we've used multiple tag sites. Specimen handling in pathology is very easy. These can be disposed, so if we have identified them in theatre, and that's usually once we've identified where the lesion is, and it's on manipulation when you're performing the wide local excision on the hole. And if the tag becomes loose at that point, then we just dispose it in the normal clinical waste. And this has been superb for multi-site operating, particularly during COVID. We've not noticed any significant procedural difficulty or complication, so with tag insertion, localization, or excision. So the insertions, the difficulties are that in particularly dense breasts, the needles can be difficult to insert through that glandular tissue. We've not had any cases where we've not been able to localize them. So it's not a significant procedural difficulty, although it is a difficulty. And the silicone sheathing on the needle has maybe helped a little bit, but I think ultimately these need to get smaller to be competitive from an insertion point of view with the other techniques. In terms of localization, we've not had any cases where we couldn't identify the tags in the operating theatre. So we have very large breasted ladies on the hole in Gateshead. There's high BMI and big breasts where I work. And yeah, we don't really find that an issue. And I suspect that's when the patients lay flat on the bed, the distance between the skin and where the tag is, even in a deep tag that you see on the mammogram, becomes a lot less when they're lying flat on the back. So I think we haven't found any issues at all, really. And we've had no problems in either the breast or the axilla. The system is small, it's robust, and it's ergonomic. The tags have fully replaced guide wires in our institution. We did have to use guide wires for about a week or so, about 4 or 5 months ago, and that was due to logistics really, and COVID, and not being able to get the equipment to us. There was a shortage of tags in the country, but that's been sorted. So we don't use tags, we don't use guide wires for anything other than if we couldn't get the equipment through. So they're fully replaced in our unit, and ultimately we've got no regrets. And it's pretty rare to have a consensus between our radiologists, pathologists, and surgeons about anything. But this is one thing that we all actually agree on. It's improved all of our working lives, improved our outcomes for the patients. In conclusion, the tags are safe and effective to localize carcinomas of the breast and lymph nodes for targeted axillary dissection. Whether or not this is the best technique, it totally depends on who's using it and what they want from their system, because there's pros and cons to each of them. But for us, it works very well, and we're delighted with the system. Just to acknowledge some of my colleagues who've helped with the data collection and projects, particularly for the targeted axillary node. And to mention that there is the Eyebrow net localization study. It's a UK-based study looking at patients who are having their hologic localizer tag. It's a pan-European study, so if you are using the tags or thinking about using them in Greece, then we'd be delighted if you signed up and put your patients into the study. Thank you.
Okay. Thank you, Mr. Milligan. I found this very, very interesting because we are using Localizer in my hospital. But let me go. So I have a few questions, but before I ask my questions, does Gianluca have any comments or questions for Mr. Milligan?
Yes, absolutely, because I recently read with great interest this study on clinical radiology, and I think as a surgeon that the most significant advantage is the possibility of marking the different lesions with the different tags provided with a unique ID number, and in the case of multifocal lesions, this could be a great help for the surgeon. And in an era like the present one, where oncoplastic breast surgeon is increasing, this is a very, very great help to the surgeon. I have just one question about the dimension of the needle used for the for positioning the tag, because I read that it is 12, if I am not wrong, 12 gauge, and this can cause some problem of migration at the insertion site. So is the use of small tag planned in the future?
Yeah, so the 12 gauge needle is bigger than the competitors, but I mean, 12 gauge needles are routinely used by our radiologists for biopsies in any case. So they're not, it's not a new thing putting a needle that size into the breast. It's not something that is abnormal, particularly when we're checking, biopsy and calcification and things. In terms of the migration, there's talk of migration, and I think it's something that needs to be clearly defined. What do we mean by migration? Is that where's the tumor, where's the tag being deployed, and where does it end up in the breast? Or when we're manipulating the tissue in theatre, can we dislodge it, or can we cut through into the surrounding fibrotic capsule and release the tag? So in terms of the pathologists, our radiologists, when they insert the tag into the breast, we've not seen any cases, apart from one, of the tag migrating back up the biopsy tract. I think when you've created a tunnel with any of these, there is a chance that if the device hasn't been fully expelled from the needle and you withdraw the needle, I think you can drag any of these back. And I had a talk on the serious intuition yesterday where they said the same thing. So I think you do create a void, and there's a possibility to pop the tags back. In terms of the tumors, because the tags are relatively large, if you're using it into a smaller tumor, my view is that the tag sometimes won't sit fully within the center of the tumor because it's too big. And if you had perhaps a 2 or 3 millimeter device or seed in there, it would sit within the tumor, and the compression of the tumor once it's gone in would kind of lock it in. If the tag's sitting not fully in it, I think the tumor might push it out a little bit as the needle comes back. I think that's the way the forces work. So some of them sit next to it, but we've not seen anything significant. These don't end up 2 or 3 centimeters away from the tumor unless you've inserted it stereotactically and you've had a rebound from the breast, or unless the radiologist hasn't taken their time. So if they aim to put them somewhere, they tend to get them very close to where they need to be. In terms of theatre, the only time really you see the tags appear is if you're operating very, very close to them. And I think it's by disrupting the area. So particularly if it's a superficial lesion and there's a biopsy tract coming anterior to the skin, if you dissect above that and the tag's not been in long enough to be well embedded and fibrosed in the area, which in our experience is usually around 7 days, I think there's a possibility that you can see that popping up through the parenchyma. And they are quite obvious, so you do see them. And I don't think that's, again, a major issue. But if I'm raising the skin flap for the dissection, I'll always, very early on in that, where I think the tumor is, I'll get the probe out and identify the area very early and put a marker stitch there, just so if there was a problem where the tag had found it dislodged, which isn't common, but if I had found that, then I would be able to know where the area was to some degree of confidence.
Thank you, Dr. Milligan.
Thank you. Mr. Mazana, any questions or comments from you?
It's really a comment, and there's lots of things that are very common between what Rob has mentioned and our experience. As I said, we're nearly on 200 tags now, and when we started putting the tags and trying to operate after 2 or 3 or 4 days, and sometimes because those are quite big, it's 2 millimeters by 11 millimeters, so they're bulky. You'll have always a small hematoma around it, and sometimes it's floating in the hematoma, and sometimes it falls. So now, if it's less than a week, we will put a wire, we will not put a tag. So we wanted to embed nicely. And there is 1 or 2 cases, like Rob has said, when it's superficial, you start dissecting, and the tag falls. And so we always ask our radiologists, if it's superficial lesion, to put it posterior to the lesion, if possible. The beauty of this is that it's a very, very, very simple thing to do. The probe is quite small. You can put it in your back pocket, and you can read from the probe itself. You can read from the actual machine itself, which is great. So you can take it anywhere to check if the tag is in the correct place. And the other beauty of it is that it gives you numbers. So you know, this is the B3 lesion, which has this number, and this is the B5B lesion. So if you're doing multifocal, multicentric tumors, it makes your life much easier. But the problem with it is the size of the size of the thing. And that's why, for example, our radiologists are still not comfortable putting it in axillas, so we cannot do TADs with them because they're not happy with that. But the company has been talking about making a smaller seed, hopefully in the future, because if they don't make a smaller seed, the other competitors are already doing some great technology with smaller seeds, and it's a big competition between 3 or 4 companies now. So if they don't go smaller, that will be an issue, I think, in the future.
Yeah, I think it's about 12 months or so, they think, until their version 2 comes out. So something along that. And I think because of COVID, there's a lot of delays with the testing. So the regulations, they all have to go and be tested by various committees. And I think all the systems are struggling with that at the minute.
Can I ask a quick question? Do you, in the UK or in Sweden or in Italy, is there a license to use localizer in the axillary nodes? Because I know that, as far as I know, they don't have a license for this. We can use it in soft tissue, in breast, but not in lymph nodes. How do you go around it?
Yeah, you're right. These haven't been licensed in lymph nodes, and I think the newer, smaller ones are going to be licensed. The company they've never said why they've not pushed for a license, because we've shown that it's safe, but they've never said why they're not planning to license it in lymph nodes. I think they're saving it for their next generation. But we were using guide wires initially, and we were using them for targeted dissections. And in our institution, our management were fairly sensible, and that we said guide wires have never been licensed for use in lymph nodes, but we use them. So they said it seems to be safe. We're using it in the breast. It's no different from what we're currently doing. So they were quite happy that we used them from that point of view. So yeah, you're right. It's not been licensed, but I think it will be when they've got the smaller technology out.
Andreas has a question, and then we'll move on to the next speaker. Okay, Andreas.
Yeah, Rob, this was a very interesting and pragmatic talk. Very good stuff as usual. What I wanted to comment on was actually the question that Professor Kontos asked. So the MAG seed has actually been licensed, FDA licensed for 6 months, and it is now CE marked, I think, before summer. The reason that all these companies avoid to do long-term markings, and this includes the SPIO too, is that if they do that, then they have to move from the medical device to the medicine category, which means that they would have to pay a tenfold in order to get the licensing. But I think that the most important thing to discuss, and the clearest conclusion from this variety of markers, is that we need, I don't see a personal reason for me to support the technique over the other. I think that since we've got things that work nearly as well with given advantages and disadvantages, we just need to push the companies in order to give us what we need, not be happy with the product with its given limitations. We need to, flip the game a little bit. And I think that all this data presented, and I'm sure that the data that Kostas will present now is going to illustrate that.
Yeah, I totally agree, Andreas. I think it's a really positive time that we have what we've never had before, which is choice. And we have gone from being told that's a guide wire, that's all you can use, to suddenly saying, well, hang on a minute, there's advantages of this product, advantages of that product. Can we combine the positives? How can we move it forward? And what can the companies do to make sure that we're all using absolutely amazing technology that's making our lives easier and the patients' lives better? So yeah, a very positive time. And I think pros and cons to each thing, and the fact that you can choose what works for you, super.
Okay, Rob, thank you very much. We're very happy to have you with us. We'll move on to Konstantinos Zachariadakis. His topic is feasibility of TAD using wireless non-radioactive markers. Which technique is ready for prime time? Konstantinos Zachariadakis is a consultant oncoplastic breast surgeon at Wrightington, Wigan and Lee NHS Foundation Trust, and he is a surgeon with experience and research on this topic. So, Konstantinos, we're ready for your speech.
Can you see I'm sharing my screen. Can you see that?
Yes.
So you see my presentation? Okay. And is it full screen now?
Yes, it is.
Okay. So I would like to thank the organizers of this session, Professor Kodos and Dr. Koudoulis, for the invitation. I have no conflicts of interest to declare. So in initially node-positive patients undergoing neoadjuvant chemotherapy that convert to clinically node negativity, converted to clinically node negativity, the optimal management remains unclear. So this uncertainty is expressed in the heterogeneity of recommendations endorsed by different national and international societies. Current guidelines vary widely, endorsing different strategies which range from axillary lymph node dissection to surgical de-escalation, replacing axillary lymph node dissection with sentinel lymph node biopsy or targeted axillary dissection. So some societies do not consider sentinel lymph node biopsy the standard of care in this setting because of the relatively high false negative rates, and have included targeted axillary dissection in their recommendations. So the UK guidelines for patients presenting with proven CN1 disease recommend removing 3 or more nodes, along with the use of dual mapping in order to minimize false negative rates. The guidance acknowledges that there is emerging evidence suggesting that marking an involved node before chemotherapy and subsequent retrieving this marked node will further reduce false negative rate. It also emphasizes that further trials are needed to confirm this finding and to standardize protocols. So 3 prospective multi-center trials, the Sentina, the ACOSOC Z1071, and the SN-FNAC trial, have evaluated sentinel lymph node biopsy in patients with clinically node-positive cancer who have undergone neoadjuvant systemic therapy. In each of these studies, the patients had sentinel lymph node biopsy followed by axillary lymph node dissection, and the primary endpoint was to determine the false negative rate. Although the reported sentinel lymph node identification rates were good overall, false negative rates were higher than the pre-specified targets. So in an additional subset analysis of the ACOSOC Z1071 trial, evaluated only patients who had a biopsy marker clip placed in the positive lymph node at the time of the initial biopsy. So when the clip node was identified and excised at the time of surgery, the false negative rate was further reduced to 7.2%. Why does removing the clip node improve false negative rate? So firstly, the clip node is not always a sentinel node. Furthermore, this is a node known to contain cancer prior to neoadjuvant chemotherapy. Therefore, pathologic assessment following neoadjuvant chemotherapy is crucial to assessing the response in the axilla. So Codle et al. From MD Anderson coined the term target axillary dissection to describe the removal of all the sentinel lymph nodes in addition to the previously biopsied lymph node. This strategy has the potential to shift the paradigm of surgical management of the axilla and opens up the possibility of innovative axillary targeting methods for directed dissection. There are numerous techniques in use for tagging the lymph node metastasis, but there are also many questions regarding the marking technique. The optimal time for marker placement and the number of marked nodes remain unanswered. The optimal number of sentinel nodes to be excised also remains a matter of debate. There's also lack of data on the oncological safety and quality of life following different staging procedures. So far, several methods for marking the target lymph nodes have been developed, usually based on techniques that are already in use for the localization of non-palpable breast lesions. Interestingly, there are notable regional differences regarding the use of various techniques, so the same method may be the technique of choice in one country while being completely unknown to another. To date, the largest amount of data has been published on clip-based target axillary dissection. Unless intraoperative ultrasound is used, this strategy requires a preoperative localization step performed either by the use of a wire or by placing another marker into the clipped area that will allow identification during surgery. Still, the success of the targeted lymph node biopsy depends on the ultrasonographic visibility of the clip inserted before neoadjuvant chemo. So the study that brought international attention to the technique and coined the term TAD was a retrospective analysis from MD Anderson. A FNA of the most abnormal appearing node was performed, and if metastasis was confirmed, a clip was placed in the biopsied node. Axillary lymph node dissection was the standard procedure for clinically node-positive patients after completion of neoadjuvant chemotherapy. So an iodine-125 seed was placed in the clip node under ultrasound guidance, usually 1 to 5 days before surgery. Dual mapping was used for the sentinel lymph node biopsy, and during surgery, the gamma probe was used in the iodine-125 setting to identify the seed containing node and the technetium-99 setting to identify the sentinel lymph nodes. All nodes containing blue and/or radioactivity were removed and labeled as sentinel nodes. Any metastatic foci, including isolated tumor cells, micrometastases, were considered node positive. So 37% of patients achieved pathological complete response in the axilla, and the pathology of the clipped node was compared with the lymph nodes from the axillary lymph node dissection. The false negative rate of the clipped node was 4.2%, meaning that in 4.2% of cases, although the clipped node showed no metastases, there were other nodes that had residual disease. The pathology of the sentinel nodes and clipped nodes was compared with pathology from the remaining axillary nodes to determine false negative rates. The FNR for sentinel lymph node biopsy alone was 10.1 and then dropped to 1.4% if evaluation of the clipped node was included. However, since only patients with successful preoperative localization were included in this analysis, it's unclear whether the clip could not be visualized in some patients, making preoperative localization impossible. Variables were associated with a clip node not being retrieved as a sentinel lymph node were the number of abnormal lymph nodes on ultrasound prior to neoadjuvant chemo and the number of sentinel lymph nodes retrieved. A similar technique for localization of lymph nodes has been reported from the Netherlands. This is the MARI procedure, which stands for marking the axillary lymph node with radioactive iodine seed, and it involves placing an iodine seed at the time of the diagnostic biopsy, which is left in place throughout neoadjuvant chemotherapy. So in their first 100 patients, the marked node was identified successfully in 97% of cases with a false negative rate of 7%. In this series, sentinel lymph node biopsy was not performed. The CENTA study is a German multicentric trial. In this study, the target lymph node was clipped before neoadjuvant in 473 patients. The markers that were used are visible on ultrasound, mammography, and MRI. And in 50 out of the 473 patients, a targeted lymph node biopsy was not attempted either because the clip was not visible upon preoperative ultrasound or targeted lymph node biopsy was for some reason not planned by the investigator. The target lymph node biopsy was successfully removed in 329 out of the 423 patients, resulting in an overall removal rate of 78% among patients in whom TAD was attempted. In 63% of patients, the sentinel lymph node and the target lymph node were identical. In the subgroup of patients who received axillary lymph node dissection, Targeted lymph node biopsy alone and TAD resulted in false negative rates of 7.2 and 4.3 respectively. Another marking method is the injection of a small volume of carbon solution into the suspicious lymph node. Now, during surgery, the targeted lymph node is identified visually by its dark staining. The results of TAD2, which is the largest prospective trial on carbon solution-based TAD, have been presented recently. In 94% of patients, the marked node could be detected intraoperatively. In 60% of cases, sentinel lymph node biopsy and target lymph node biopsy were identical. And in 4.5% of patients, unintentional tattooing of the skin was observed, but it remains unclear whether this effect is permanent. So in this subgroup of patients that had axillary lymph node dissection, the false negative rate was 9.1%. And a similar false negative rate of 8.3% was reported from the only other study on false negative rate in carbon solution-based TAD. Moving to Maxi localization, this is a prospective study from MD Anderson, who have moved from radioactive seeds to MAG seeds. So the magnetic seed was placed under ultrasound guidance in this study in the clip node after completion of neoadjuvant chemotherapy and up to 30 days prior to surgery. All patients had successful seed placement at their first attempt, and there were only 2 cases where the MAG seed was identified more than 3 millimeters from the node, and 1 case where the node could not be adequately visualized, but the MAG seed was located next to the clip. The magnetic seed was retrieved at surgery from all patients. Another retrospective cohort from the US reporting on their experience with the radar reflector localization guided TAD. In this study, 16% of patients, in 16% of patients, the clip was placed prior to neoadjuvant chemotherapy, and it was accurately localized in the clip node in all patients. The median number of lymph nodes the median number of lymph nodes was 1, ranging from 1 to 4, because in some patients, adjacent nodes were excised along with the clip lymph node. So Mokbel et al. From the London Breast Institute conducted a systematic review in order to evaluate the false negative rate of target lymph node biopsy alone and in combination with sentinel lymph node biopsy, which is TAD, by pulling the data from relevant studies. Analysis of studies reporting on the success of localization and retrieval of the marked lymph node revealed a successful retrieval rate of 90%. The analysis included 9 studies with a total of 366 post-neoadjuvant chemotherapy patients with biopsy-proven node-positive breast cancer that underwent target lymph node biopsy in addition to axillary lymph node dissection. And of these, 22 false negative results were recorded, yielding a false negative rate of 6.28%. 12 studies evaluated the addition of target lymph node biopsy to sentinel lymph node biopsy, which is TAD, with an overall false negative rate of 5.18%. Statistical analysis showed that the differences in false negative rate between target lymph node biopsy and TAD was not statistically significant. So when should the lymph node be marked? To date, there's no consensus on the optimal time point of marker placement. In most studies, lymph node metastases were confirmed by FNA or core biopsy. If a minimally invasive biopsy is performed, the marker may be inserted into the lymph node at the same session or at the second session upon confirmation of metastases. Data on this aspect lack detail in available studies, but most authors report the placement of the marker into the previously proven node. There are advantages and disadvantages for both strategies. Marking the node at the time of the biopsy ensures that the biopsy lymph node is the one that is marked. Furthermore, the patient undergoes only one invasive procedure in one appointment. On the other hand, marking the node after confirmation of metastatic disease ensures that a marker is placed only if we plan to proceed with TAD. However, in cases with more than one suspicious lymph nodes, the marker might be placed in a non-biopsied lymph node. Furthermore, a second invasive procedure is necessary. How many lymph nodes should be marked? Since TAD is a relatively new technique that still needs to be validated and standardized, various institutions follow different strategies. So far, there's no consensus on the number of nodes that should be marked in patients with more than one suspicious lymph node on imaging. And while most studies report the marking of a single node, it's unclear which lymph node was selected for biopsy and marking in these cases. So options vary between the largest, the most suspicious, or the best accessible node. Other authors report marking all suspicious nodes. Both strategies offer their own advantages and disadvantages. Regarding the accuracy of lymph node assessment, marking only one axillary lymph node in case of patients with several suspicious or biopsy-proven nodes might increase the false negative rate, since the marked lymph node might be free of tumor, while other previously suspicious but not marked lymph nodes may still contain tumor residuals and remain in situ. Heterogeneous or mixed axillary response to neoadjuvant chemotherapy, where you get lymph nodes with no or partial response along with lymph nodes with pathological complete response, is common and can be diagnosed in up to 74% of patients with hormone receptor positive HER2 negative disease, followed by 29% in triple negative and 25% in HER2 positive tumors. Lim et al. Conducted a complex study in order to explore false negative rates of different target lymph node biopsy strategies. So after neoadjuvant chemotherapy, all patients received target lymph node biopsy followed by axillary lymph node dissection. The first clip node alone had a false negative rate of 7.1, which sank to 0% when the second clip node was taken into account. Sentinel lymph node biopsy was not performed, and it remains unclear how this might have influenced the false negative rate. Marking all suspicious nodes will necessarily result in removal of more lymph nodes, but how this will affect our morbidity and quality of life remains unclear. So Nasiopoulos et al. Conducted a carbon solution-based study in 75 patients, marking each biopsy-proven or strongly suspicious node. The median number of lymph nodes marked was 2, with a range between 1 and 5, and during surgery, between 2 to 10 nodes were retrieved. Now, how this relatively high number of removed nodes may affect quality of life and our morbidity remains to be clarified. However, on the other hand, patients with multiple involved lymph nodes, in patients with multiple involved lymph nodes, this strategy increases the accuracy of staging and reduces false negative rate. Importantly, a clinically relevant balance between high accuracy, which would require more extensive staging, and low morbidity, which is less extensive staging, must be found. It's unclear whether all clinically node-positive patients can safely omit completion axillary lymph node dissection in case of negative axillary staging following neoadjuvant chemotherapy. So far, while none of the studies on TAD have reported oncological or quality of life outcomes, there is limited information available on sentinel lymph node biopsy alone in this setting. So Calle, Ribeiro, Fontana et al. From the European Institute of Oncology in Milan have reported on the long-term outcomes following sentinel lymph node biopsy after neoadjuvant chemotherapy. And among 222 clinically node-positive patients, 123 had no residual disease on sentinel lymph node biopsy. Of these, only 2 patients developed axillary recurrence. Among all CN1 and CN2 patients, there were no significant differences found in 5-year and 10-year overall survival between patients who received axillary lymph node dissection and those in whom axillary lymph node dissection was omitted. Most Cad validation studies include a heterogeneous group of patients. In the pivotal study by Cordell et al. From MD Anderson, patients presented with at least 4 abnormal nodes on ultrasound. Similarly, in the largest study on carbon solution-based TAD, 25% of patients had more than 4, and there were 4% of patients that had more than 10 suspicious nodes before neoadjuvant chemotherapy. 29% of patients that enrolled in the central trial had at least 3 abnormal nodes. Intuitively, the more suspicious nodes on initial ultrasound, the more probable it is for TAD to miss residual disease, especially in cases where only 1 node was marked, thus resulting in a higher false negative rate. Other factors that can improve identification of patients who do not benefit from completion axillary lymph node dissection are breast response to therapy and tumor subtype. So a multivariable analysis by Cantor et al. Showed that pathological complete response in the breast was the most important predictor of PCR in the axilla. Other studies have also reported a strong association between response in the breast and in the axilla, particularly in patients with HER2 positive and triple negative breast cancer, implying that tumor subtypes should probably also be implemented into a potential decision-making algorithm. Since patients with HER2 positive and triple negative cancer achieving complete radiological response in the breast have the highest probability of reaching axillary pathological complete response, they are probably more most likely to benefit from de-escalation of surgical treatment such as TAD. There are several ongoing trials investigating de-escalation of axillary treatment in patients undergoing neoadjuvant chemotherapy. So the AXANA trial is a prospective multinational non-interventional cohort study that is currently open in Greece and is recruiting patients in 3 hospitals in Athens and Thessaloniki. In my unit, we're recruiting patients for the ATMEC trial, which is a UK multi-center phase 3 randomized clinical trial with a non-inferiority endpoint. The main objective of the trial is to assess whether axillary treatment can be omitted in patients with no residual disease on TAD after neoadjuvant chemotherapy without affecting invasive disease-free survival. So patients with T1 to T3 N1 disease undergoing neoadjuvant chemotherapy are eligible for the trial. Axillary nodal metastases needs to be confirmed either by FNA or by core biopsy. The positive node is marked either by placement of a clip or by spot DITA-2, and ultrasound of the axilla is performed at completion of neoadjuvant chemotherapy to confirm clinically node-negative axilla. So patients undergo dual-agent blue dye and radioisotope TAD after neoadjuvant chemotherapy, and at least 3 nodes should be removed, including the clip node. Patients with no nodal metastasis post-neoadjuvant chemotherapy and axillary surgery are then randomized to one of the 2 arms, axillary treatment or no axillary treatment. The study's protocol allows the use of any of the previously described marking techniques. So in the first patients we recruited, we placed a hydroclip that is ultrasonographically visible in the involved node prior to chemotherapy. Response to treatment was assessed with MRI as per unit's protocol, and after completion of neoadjuvant chemotherapy, the axilla was reassessed on ultrasound, and if complete radiological response was confirmed, the hydroclip was identified and a MAGSID was placed for localization. We have now simplified our protocol and placed the MAGSID in the involved lymph node prior to chemo. Therefore, it stays in situ until TAD is performed. And we try to organize the first MRI prior to MAGSID placement so we can assess the axilla without any artifact from the MAGSID. So as a conclusion, I would like to say that in view of the continuously improving primary systemic treatments with increasing response rates, there is an urgent need to adapt and de-escalate strategies for axillary surgery since it's strongly associated with postoperative morbidity. And although many questions regarding the optimal marking technique remain unanswered, there's early evidence to suggest that TAD is safe and a safe method that reduces the high false negative rate of sentinel lymph node biopsy in this setting. There's no clear evidence to support one technique over the others. Therefore, any decisions will be based on local preferences, expertise, logistical factors, and obviously cost. Finally, I would like to encourage the creation of local prospective databases and registries that would allow any unit that adopts TAD to audit their outcomes and document any adverse events. And this could lead to the creation of a network or a platform under a HEM where surgeons can share knowledge and experience. Thank you. And these are some further reading.
Thank you, Kostas, so much. I think you managed to summarize what is going on with TAD nowadays. We have a few minutes for questions. Gianluca, any questions or comments from your side?
First of all, I want to thank Professor Zacharidakis because I think that...
I'm not a professor either.
Okay, doctor. I think that among the various challenges, this is certainly the hardest now. The ACOSOG, the Sentina, the SNFNAC showed false negative rate after NAC of about 13%, and the sentinel node identification rate of 85%, more or less, and the positioning of a clip in the positive lymph node as NCCN advises seems to be the only solution now. But I think also that we are still in the learning curve. And the results of the MARI procedure of the use of MAGSID and SaviScout are promising, but I still have some practical doubt in my personal experience. For example, what to do in case of difficulty in the preoperative ultrasound identification of the clip due to the fibrosis induced by the therapy. This happens very often to us. Maybe we can use a more echogenic clip? And also another question, what to do in case of intraoperative non-identification of the lymph node? Because sometimes we use also intraoperative X-ray in cases like this, or it's mandatory to perform an axillary dissection. So thank you so much. I think that this was a very, very impressive presentation.
So if I can comment, I completely agree with what you said, and what we see in some of the studies where they place the clip and then try to identify it after neoadjuvant, the identification rate was between 85 and 90%. That means in 10 to 15% of patients, they were unable to identify the clip. And that's one of the reasons we have moved to placing the mag seed at the beginning. Therefore, in most studies on these newer localization techniques like MagSeed, the identification rate is close to 100%. So if you place the clip beforehand, you won't miss it. Another problem that, in my experience that I've had with placing the MagSeed prior to surgery is you can have a hematoma, and I think Yazan mentioned that before. And if it's close to when you do TAD, I ended up in a case removing the node that had the MagSeed, but also removing 5-6 more nodes that were in a hematoma, like a mass. So it makes it a bit more challenging if you place it very close to when you're going to do the surgery. And you don't get that problem if you place the MagSeed beforehand.
Okay, thank you.
Andreas, so you have a question?
Not that much of a question, but rather a comment. Congratulations, Kostas. I wrote that the axilla is a mess, but you managed to tidy up the mess very efficiently. So regarding the TAD techniques, it is still a question of taste and preference, and what do you want to do? We are currently doing a network meta-analysis because I had a talk on the ESO about the magnetic TAD, and we had already started on this project. What Kostas is suggesting is what the data show. So if you try to clip a node in a way and you have response, finding the clipped node is much more challenging in order when compared to clipping it with the marker that you will be using. That's the one thing. This is not me, it's what the numbers are showing, and it is consistent regardless of if it is a mag seed or an iodine seed or whatever. It seems the RISAS study, which is the Dutch version of TAD, Marian TAD, that was presented in San Antonio last year, but we don't have any published definitive results yet, highlights this thing even more. And I think that it kind of addresses the idea of the challenges that we saw in the CENTA study. I see that Stefan Papke is with us, and he may be able to comment on that, which reflects what Kostas was talking about, that when you've got response and you are very enthusiastic in moving on with the TAD, well, good luck with finding the node. And this is something which is very important. Last but not least, regarding the number of pathological nodes, I will just need to highlight the Lucerne toolbox published on Lancet Oncology, which is a policy review on how to do de-escalation. The data suggests that N2 tumors prior to neoadjuvant treatment are those that have less chance to become node negative. They are those that have a higher false negative rate. I think Professor Kondos recently published a paper that illustrates that very, very beautifully. And finally, it is these tumors that will have the highest risk for local recurrence, regardless if you've got a PCR or not, which in turn is, however, the most predictive parameter for recurrence or not. So patient selection and smart standardization of techniques is what is the crucial thing here, I think.
Can I add? Just, I completely agree with Andreas. So I think more important than choosing the best technique is choosing the best patient for TAD, I think. So obviously, N1 disease, it's preferable than N2. For example, in the ATNIC trial, we're not allowed to recruit any N2 patients. And this is part of the UK guidelines as well. But also, I think the molecular subtype of the breast cancer is important, because with HER2 positive and triple negative cancers, it's not that you just get a higher pathological complete response in the axilla. You also get less often a heterogeneity of response, where you get some nodes that have complete response and other with disease, and that increases the false negative rate.
I so much agree with you, Kostas. I think surprisingly, the subtype of the cancer is not taken into account in these trials. First, and second, I just want to highlight the fact that when the marked node is not the sentinel node, then the false negatives is high as well. Because we're running out of time, Mr. Mazanat, any comments from your side? Any questions? No?
No, I think it's great talks. Many thanks, everybody. It has been great, really.
Theodoris, you want to conclude the session?
Yes, thank you very much. I would like to thank all the speakers and the panelists for their participation. It was a fantastic panel. I think we should move on to the next panel, which has also very experienced breast specialists. So, Corina, you should introduce us to the next panel.